Hi everyone, how are you? Today we are going to start another question regarding MRCS. Based on eMRCS, we will discuss all the eMRCS question, recalls, and Fawzia sheet for your easy pass to MRCS Part A exam. So if you are a new visitor to the channel, you can subscribe the channel for new videos because we will deliver at least 2 videos in 24 hours. So stay tuned with us by subscribe the channel. So let's start the question. Here we can see the question is, you review a 42 years old woman 6 weeks following a renal transplant for focal segmental glomerulosclerosis. Following the procedure, she is discharged on a combination of tacrolimus, mycophenolate, and prednisolone. She has now presented with 5 days history of feeling gradually unwell with anorexia, fatigue, and arthralgia. On examination, she has a temperature of 37.9 degrees Fahrenheit, 37.9 degrees Celsius, and has widespread lymphadenopathy. What is the most likely diagnosis? Here we can see 42 years old women 6 weeks following renal transplant. So this time is very important for us. She present with us with complaints after 6 weeks following the renal transplant for focal segmental glomerulosclerosis. Following the procedure, she was discharged on a combination of tacrolimus, mycophenolate, and prednisolone. They are the immunosuppressive. Now she has presented with 5 days history of feeling generally unwell. That means they with anorexia, fatigue, arthralgia. They are the feature of infection. Anorexia, unwell, fatigue, arthralgia, they are the symptom of infection or inflammation. On examination, a temperature 37.9 and widespread lymphadenopathy. So here we can see all the symptoms. They are related with the inflammation. So here, what is the most likely diagnosis? Here we can see hepatitis C, coccic virus, HIV virus, hepatitis B virus, and cytomegalovirus. So we have to find out which of the virus may cause this type of illness for a immunocompromised patient, because we gave the patient combination of some of immunosuppressive agent. So here we have to find out, in case of immunosuppressive patient, of a renal transplant patient, which causes the infection and inflammation of the patient. Here we can see about the transplantation reaction or rejection. Here we can see hyperacute, acute, and chronic graft failure. Here hyperacute occurs due to antibody against HLA type 1 antigen. Here is the antibodies, but rarely seen due to HLA matching. HLA mismatching causes rarely, because all of the time we match the HLA of the donor and recipient before the transplantation of the kidney. So HLA mismatching is very rare for hyperacute rejection, and HLA matching usually requires a longer time. HLA mismatching usually requires a longer time for its reaction. But when antibody is preformed, it is ready for a wear, it is ready for a action. So any antigen enters into the body, it reacts immediately. So hyperacute reaction, it is occur, or hyperacute rejection of the transplant kidney, it is occurred due to a preformed antibody against HLA. Then acute graft rejection, it occurs within 6 months. This time is very important. On the other hand, chronic graft rejection or failure occurs more than 6 months. So these two timing is very important. Acute graft rejection occurs within the first 6 months of the transplantation, and chronic rejection occurs more than 6 months after the transplantation of the organ. So in case of acute rejection, usually due to mismatched HLA that we have seen here, because in case of mismatched HLA there is a longer time to react time. On the other hand, some of the viruses such as cytomegalovirus. So in case of acute case, cytomegalovirus is responsible for graft failure within the 6 months, and in this case we saw this is 6 weeks, so it is within the 6 months. And management usually give steroid. If resistant, then use monoclonal antibody. So for the treatment of the acute rejection, we can give steroid. If steroid not work, then monoclonal antibody. Then causes of the chronic graft failure, that means more than 6 months following the surgery. After the 6 months, if the graft failure occur or graft rejection occur, then it is called chronic graft rejection or chronic graft failure. The causes are chronic allograft nephropathy, ureteric obstruction, recurrence of original disease. So chronic allograft nephropathy, ureteric obstruction, or recurrence of the previous disease of the patient such as MCGN, IgA and FSGS. There it is most common in mesengiocapillary glomerulonephritis, then second common IgA nephropathy, then third common focal segmental glomerulonephrosis. So in case of glomerulosclerosis, so in case of mesengiocapillary glomerulonephrosis, it is very common for chronic graft failure and IgA then and focal segmental glomerulonephritis after them. So these points are very important: hyperacute, acute and chronic. Hyperacute, acute and chronic. In case of hyperacute graft rejection, it occurs due to preform antibody. In case of acute rejection, it may be due to cytomegalovirus or mismatched HLA. These 2 points is very important. And causes of chronic graft failure, they are chronic allograft nephropathy or ureteric obstruction, or maybe previous renal disease. So here our final answer is cytomegalovirus, because it occurs within the 6 weeks. That means it is within the acute condition. And here we can see the sign symptoms: anorexia, fatigue, arthralgia, fever and widespread lymphadenopathy. They are signs of inflammation, signs of infection, and it is occurs due to cytomegalovirus. Hepatitis C and hepatitis B usually transmitted by the blood, not in immunocompromised patient. HIV, it causes immunocompromisation, but it not occurs in immunocompromised patient. And Coxsackie virus, it also not occur. And usually in immunocompromised patient, disease occur by patient's own bacteria, which was natural at the time, but when immunocompromised, then it develops. So our final answer is cytomegalovirus. Thank you.